My name is Emily, one of the locum consultant in LRI ICU. We are going to talk about management of sickle cell disease. So we're going to look at definition, the genotypes, pathogenesis, complications of acute and chronic, and their management, perioperative management, and transfusion. Okay, so what is sickle cell disease? Sickle cell disease is multisystemic. It's multisystemic disease. It's inherited. It presents from childhood. Um, what happens is that there's inheritance of gene coding of abnormal beta globulin that come from both parents to get the sickle cell disease, and at least one of the beta globulin has to be carrying a sickle gene. Um, what a sickle gene means is that it's substitution of valine for glutamic acid at position 6 of chromosome 11, which codes for the beta globulin, resulting in what we call HbS. HbS is a quite a hydrophobic hemoglobin that in low oxygen states results in polymerization. And when that results, it results in change of the shape of the RBC into what we call a crescent shape or a sickle shape, which therefore leads to hemolysis and vaso-occlusion of the microcirculation. And that's how the complications result from the microocclusion and hemolysis. The most severe form of sickle cell disease is sickle cell anemia. Sickle cell anemia means it's a homozygous state, which whereby both beta globins are carrying the sickle gene. So there's a HBSS, which is the most severe form, and usually the typical steady state HB value is 60 to 90 grams per liter. Then there's a milder one, which is HBSC, with one sickle gene and one hemoglobin C, which is milder, and HB is usually 90 to 140 grams per liter. In HBSS, patients will have come in with vaso-occlusive crisis, painful crisis, strokes, acute chest syndrome, organ damage. The milder one, which is HBSC, the common one is retinopathy and avascular necrosis. They would have fewer pain crises. The other types of sickle cell disease is HBS with beta thalassemia major, which is a severe form, and beta thalassemia minor. There's HBS, D, Punjabi, E, and many others. Epidemiology, 80% of sickle cell patients with sickle cell disease are from Afro-Caribbean origin, with 80% of patients who have sickle cell disease in Africa. It will also be found in Mediterranean areas, in Arab areas, and in South Asia. You'll find that the HB sickle cell disease and trait, usually the distribution is along the malaria endemic zone. This is because it's a gene that protects against malaria. Okay, we have talked about that. The triggers for sickling are things like hypoxia, dehydration, infection, acidosis, hypothermia. And the main goal when managing this is avoiding all these triggers or treating all these triggers. At birth, just to note, that children are born with HbF, which is a gamma and an alpha globulin. But at 4 to 6 months of age, there's a changeover from gamma to beta, and that's when the disease starts presenting. So you'll find a child coming at 6 months of age with dactylitis, which is a common thing in the beginning of the disease. If you see that, then suspect. We find that you'll have patients with the same genotype. For example, they have HBSS, but the severity of disease is quite different. Some are more severe disease, have a less severe disease. And most of this is explained by the differences in the phenotype modifier. So some patients will have this hyperactive endothelium that results in increased adhesions of sickle cells and platelets and leukocytes that then worsen the blood flow, microcirculation. Some will have the abnormal vasomotor tone, whereby there is a decreased nitric oxide, so the vasodilatory effect of nitric oxide is not there, which worsens the severity of the disease. These are the patients whom you'll mostly find coming in with things like pulmonary hypertension as one of them, strokes. Yeah. Okay, what are the chronic complications? This is a whole long list of chronic complications, which I won't go through each and every one of them. As we know, patients have persistent hemolysis, so they'll have chronic anemia. And that's why it's usually important when you have a patient who has sickle cell disease, it's always good to know what their steady state HB is. Some will be 60, and that's just enough for them. Know what the reticulocyte count is. This is usually monitored from the community, so that if there is a change in the reticulocyte count that it's starting to creep up, then start suspecting things like hemolysis. So you need to know their baseline as well. For chronic anemia, consider things like hydroxyurea or hydroxycarbamide. Why? Because the hydroxycarbamide tends to increase the HbF level, which is a bit protective. Other things are avascular necrosis. As we said, it is quite common in HBSC. Leg ulcer due to venous insufficiencies, pulmonary hypertension, renal impairment. Renal impairment, usually they benefit from things like ACE inhibitors, retinopathy, and chronic pain syndromes. This is usually from all the vaso-occlusive diseases of the maybe sternums, long bones, ribs as well. The acute complications of the disease are most of them are actually vaso-occlusive. I know I've written there vaso-occlusive crises, but most of the complications are vaso-occlusive. And one of them, effect of vaso-occlusive, is a pain crisis. And that is the most common presentation in these patients coming in with a pain crisis from vaso-occlusive episode. It could be in the long bones, as I said. It could be from things like the ribs, the sternum, mesentery. Yeah. The triggers usually are infection, dehydration, hypoxia, stress. And the management, most of the cases, is just analgesia, treat infection, manage hypoxia. And we say incentive spirometry for whatever they come with. Incentive spirometry is encouraged because if it's pain or whatever it is, you do not want them to end up with things like VQ mismatch from atelectasis and so on, because that's how they end up developing acute chest syndrome. So you'll find enough of patients coming in with a different types, a different type of crisis, but they end up in the hospital with things like acute chest syndrome because of VQ mismatches. Yeah. Acute chest syndrome is the leading cause of mortality in adults. And how it happens is that it needs to just have a small, maybe small zone of poor ventilation, be it because of an infection, atelectasis, be it because of pain, which can definitely result in that. So the poor ventilation will then result in hypoxia and acidosis, and hypoxia and acidosis will then result in sickling, and the microcirculation is occluded. Plus, The hypoxia results in vasoconstriction. All that results in poor perfusion and then further worsening hypoxia and acidosis and VQ mismatch. And this patient can spiral very, very quickly into severe hypoxia, and that's why the mortality is high. So when you have a patient presenting to you with chest pain, fever, hypoxia, tachycardia, tachypnea, um, they might have new infiltrate on chest X-ray, might not have. Then you need to be quite have low threshold of transfusing this patient. The management is usually oxygen, antibiotics, analgesia. And as you've seen, we've had a few patients who've come in with acute chest syndrome here and who've had exchange transfusion for that. We will talk about exchange transfusion and other transfusions later. We have complications like stroke. Most common is ischemic, and that is also vaso-occlusive episodes. The patients, as I said, who are more prone to this, those are the ones who have a different phenotype that is severe. So ischemia is the commonest, and you'll start seeing it in children. We have about 11% of patients will have, by the time they're age 20, they would have clinical evidence of ischemic stroke. The other, about 22% will have a silent stroke. So with advance in management, these patients who have sickle cell disease usually start being monitored for any signs of stroke. The ones who are high risk, they will do transcranial Dopplers. The transcranial Doppler helps to tell if the patients are at risk of stroke. And if they are at risk of stroke, then those are the patients who sometimes go on long-term chronic transfusion. For patients who are coming in with stroke, the treatment is exchange transfusion, and then end up on long-term chronic transfusion for prevention. Splenic sequestration, which is quite common in children who will come in hypovolemic shock, severe anemia, and this is as a result of pooling of blood in the spleen. These patients would need as well transfusion. Then there's a plastic crisis that comes from parvovirus B19, and the supportive care is the treatment and transfusion as required. Priapism, which is also a vaso-occlusive event, these patients don't need transfusion. They sometimes need urology referral for stents or drainage. Other complications are infection, which are also quite common. What are the peri-op management of this patient? The key principles are patients who come in with sickle cell disease. We need to remember that they have there's a risk of complications from the sickle cell disease, and the risk of complication from none, not associated with sickle cell disease, is very high in this patient as well. So your goal is to minimize the triggers, as we have said, with the hypoxia, hypothermia, hypotension. Pre-op management. It needs multidisciplinary planning, whether they're having a surgery, high-risk surgery, or even sometimes minor surgery, depending on the patient. We need, it's, as we say, multidisciplinary. We have a lot of support here from hematology team. You need to also liaise with people like the lab transfusion technicians as well. You need to understand, as you're assessing this patient, what is their baseline HB? What are their baseline reticulocyte count? Have they had transfusion? What is their transfusion history? What are the antibodies, the alloantibodies that they have? This, luckily here, most of the time, the hematology team are usually on top of this. And you need to understand what kind of organ dysfunctions and comorbidities they have. You'll find that most of these patients have had multiple transfusions, and they have antibodies that sometimes are quite rare and require very special blood. So this needs to be requested as early as possible or organized as early as possible. The other thing that you need to keep in mind, there is the fact that they've had multiple transfusion. You need to have the HIV screen, Hep B and Hep C screen. Know what their vaccination status is. As for patients with sickle cell disease, by about 6 months, 90% have functional asplenia. So they are at risk of um, infection with the encapsulated organism like Haemophilus, pneumococcal, meningococcal. They need to have had those vaccine. Hep B vaccine is also recommended in these patients. Pre-op, other pre-op managements, you make sure that maybe drink till you send, give them IV fluids. Um, and prophylactic antibiotics is usually given, penicillin for pneumococcal because they're at risk. Intra-op management, as we said, avoid the triggers or treat the triggers, manage the triggers. Yeah. Monitoring, close monitoring as well for oxygenation and temperatures and hemodynamics. Regional anesthesia is encouraged as well because pain is something that you would want that to be under control by the time patient is getting out of theater. Tourniquets, sometimes before it used to be no tourniquets for patients who have sickle cell disease, but if it means reducing the risk of bleeding, then tourniquet is something that should be considered. Only that it should not be go on for long. This is because there's the whole risk of sickling. Post-op care, the usual pain control is very, very important. Ensure that the pain is well controlled, nausea and vomiting, ensure the patient is warm, give adequate painkillers. As we said, if the patient does not have adequate painkillers, there's a risk of things like atelectasis and then acute chest syndrome. Give them incentive spirometry. They're at increase of thrombosis, so they need VTA prophylaxis. Then watch for all the acute complications like acute chest syndrome, infection, and vaso-occlusive crisis. This is just a special note. It's patients with sickle cell disease avoid doing day surgeries because of they are quite high risk. Okay, when it comes to transfusion, what do we mean by transfusion? Transfusion can be just a top-up transfusion where you just give blood. That still reduces the HbS, or you can do what you call an exchange transfusion, which I'll speak about. Transfusion is used for mostly acute complications, as I had mentioned. If a patient comes with stroke, they need exchange transfusion. Acute chest syndrome, they need exchange transfusion. Things like sequestration, there is no strong evidence on using it, but still, depending on the patient's condition, an exchange transfusion can be done or a top-up transfusion can be done. A plastic crisis, mostly top-up transfusion and just supportive care. Then there's a transfusion, long-term transfusion for chronic therapy, as a chronic therapy. And this is mostly for the patients who are at high risk of stroke or who have had stroke, or patients who are coming in with things like multi-organ disease. You can consider long-term transfusion. The whole goal is to reduce the proportion of HbS. Usually the aim is to get to a HbS of less than 30% and also to increase oxygen carrying capacity. Now, the complications with transfusions are things like, apart from infection, there's hyperviscosity. We have to be very careful. Sometimes a patient comes with sickle cell disease, and when you see that HB is 70 or 65, we get concerned and we transfuse. But we have to remember that these patients already have a kind of a steady state HB, which is acceptable for them. So before you transfuse, think about what is their baseline HB level, what is their transfusion history, and HbS 30. If their HbS level is quite high and you end up over transfusing, there's a risk of hyperviscosity. And when you result with hyperviscosity, microocclusion, and crisis, so it becomes another vicious cycle. Um, it's usually recommended when you're faced with a patient who usually has low HB, try, if you're going to transfuse, don't go beyond the 10 to 20 grams per liter above the baseline HB. Yeah. Patients with chronic who are on long-term transfusion, those ones are less to worry about because their HBS is already low. And since their HBS is already low, if you take up the hematocrit high, they're not at high risk of sickling. Yeah. Make sure you do. They need ABO compatible blood. Has to have Rhesus and KEL matched and HBS negative units. Usually should be admitted in a hospital where they can do extended RBC antigen typing so as to try and see if there are any other autoantibodies. Um, the extended, sorry, the blood, the blood should be less than 10 days old for top-up transfusion and less than 7 days for old for exchange transfusion. However, you will find those patients who have multiple antibodies with rare blood that you still have to give um, old blood. As I said, this is either top up or exchange. Exchange can be automated. It can be manual. Manual, it means you draw blood and give more blood. Yeah. Only that in most of those cases, the amount of blood you're giving is less than what you're drawing. So you will need to give more things like crystalloids as a top up for volume. As for the automated one, it removes the plasma, leukocytes, and platelets, and that is given back. Yeah, only red cells are exchanged. The risks of hyperviscosity with exchange transfusion is lower. So, indication for exchange transfusion, I think we have said acute stroke, chest syndrome, multi-organ failure, any patients who is coming for a high-risk surgery despite whatever genotype they're presenting with, all genotypes, they need to have an exchange transfusion as long as they're having high risk surgery. Then for those who are having medium risk surgery who have HBSS and HBSC, those ones need exchange transfusion as well. Yeah. Chronic transfusion program, I've already mentioned them when you need them, especially for the stroke patient or multi-organ disease. The issues with that is definitely the infection, as mentioned, and iron overload, which usually is monitored, and allo immunization. Patients need to be cancelled for this. Just a special mention is hydroxycarbamide, which is also used for these patients who are on long-term chronic transfusion programs for stroke. Hydroxycarbamide, as I said, helps in increasing the HbF. Plus, it helps also increase the nitric oxide. It also helps reduce cell adhesions on the cellular adhesion on the endothelium, and this tends to reduce the risks of stroke, of pain crisis. So this is something that has been used, and some patients actually end up coming off long-term transfusion and being established on hydroxycarbamide. And I think that is all. Any questions?
Sorry, we said it. For exchange transfusions, access wise.
So yes, I know. We are always told put a vascath. Really, there is no there's no reason to put it. Can even be done on a peripheral cannula. Yeah.
Good.
But it means that the flow can be a bit an issue and it can take a while to do the, yeah. So most of the time when you have these patients who are coming as an emergency, you don't want to be sitting there waiting for the exchange transfusion to finish. Central line is good enough. Even a femoral central line is good enough, really. Yeah. But I think it's the preference of the nursing team here as well. They prefer the vascat because it's a big catheter and the flow is just quickly and they won't bother. Anything else? Any other questions from the Glenfield team? I hope they're still there. Yes, well.
Yeah, I think the question is for sickle people admitted to ITU for non-sickle crisis, like they are not in acute chest syndrome and also they are not surgical. Are we following the targets as preoperative target like hemoglobin of 10 and or sickle hemoglobin of 30 to 40%, or do we can just accept whatever they have as long as they don't have complications?
Oh, so for anyone who comes in that is not in sickle cell crisis, as I said, all you need to do is keep them at their state, at their HB state. There is no need of targeting all that, and then avoid the triggers.
All right, thank you.